ഫസ്റ്റ് അജണ്ട മാത്രമേ വന്നുള്ളൂ, ബാക്കി വന്നു. നമ്മൾ ഇതിൻ്റെ തന്നെ ഓഡിയോ സ്റ്റാർട്ടോ വീഡിയോ എന്ന് വെച്ചാൽ നമ്മൾ അങ്ങോട്ട് സംസാരിക്കേണ്ടതാണ്.
Okay, so the agenda for today, we have 3 items. I'll give you an update on the project, the progress of the project so far, and then we'll have a presentation from one of our great participating site from Asir Central Hospital, who are doing a really remarkable job in this project. So it'll be presented by Dr. Hassan Lashi and Ms. Sarah Malki. And then there will be discussion on VE definitions and collection by Dr. Saleh Qasim. Slide. Okay, so just to remind you that the website for the NASAM has many resources, and we like to keep it updated so people who have things want to upload can do that. Yesterday there was a question about the subglottic suctioning protocol, and some of the information is already in the presentations that are posted in the website. So you can utilize this. If you have a protocol you like to share with the others and you want to have it posted, we'll be more than happy to include it there. In terms of data collection, I think we're maintaining same level. I think overall we're seeing more green than red lately. So I think this is good that sites are doing more, or ICUs are doing better in progressing with data collection, and we need to keep it up because this is how it guides our change. This is an NASAM data. This is the mobility data. Also, I think there's some improvement recently. The VE is still, some ICUs are doing remarkably well. Some don't have much data entered, so we need to encourage people who collected data to enter it, who didn't collect data to try to do it, and we're going to have presentation on the VE. Similarly, the objective outcomes are critical. The mortality, length of stay, this data is needed, important for the project, as you know. So I'm not going to spend more time on this. I'm going to let Dr. Hassan Lashi and Ms. Sarah Malki give their presentation on air mobility and their experience. They are doing really great job. But I think when we look at air mobility, we should look at it as part of the whole project, because you cannot do air mobility of patients sedated. So this all it's kind of multi-dimensional. You have to achieve all of them to achieve the end result. So air mobility is part of the whole project. But I think there's some excellent experience from many ICUs, and Asir Central Hospital has done a remarkable job in this. So Dr. Hassan, if you want to start, please go ahead.
Good afternoon.
Yes, good afternoon.
Good afternoon, everyone. I am Dr. Hassan, ICU specialist and the team leader of NASAM project in Asir Hospital. I want to thank all of you, and also I want to welcome my colleague, Ms. Sarah Al-Malki, the supervisor of the mobilization team in the ICU. If we can start our presentation, please, Cheryl. Yeah, so first of all, I want to focus on some things very important to succeed any project, especially what lead to success in Asir Hospital, the leadership. Really, we are receiving a great support from the head of department, Dr. Ibrahim Asiri. Without such man in the leadership, I think to achieve such success, it will be like either impossible or at least difficult. So I want to thank him really for his support and his all efforts with us.
Yeah, Dr. Hassan, can you come closer to the microphone?
Okay, like that?
More.
Hello?
Yeah, can you get closer to the microphone?
Actually, I'm talking from my headphone.
So
is
just
it okay
speak
like
up.
this? Okay. Is it okay?
Yes.
So I will go ahead. Is it okay, the sound now, the voice?
Yeah, much better.
Yes.
Yes, Dr. Hassan, go ahead.
Okay. So really thanks for you, Dr. Ibrahim, for your support and the other administrative regarding the hospital director and even the general directorate. And all NASAM team leader. When we are, can I have the next slide, please? Yeah, when we are talking about NASAM successful and especially in the mobilization, as our webinar today about the mobilization, it is really a teamwork. Without team, what we mean with the teamwork, if we can take the next slide, which is video, I will show you what the real meaning of teamwork in mobilization in Asir. This is a patient. We are trying to mobilize him of level 2 mobilization. This is 70 years old patient, CVA, heart failure, intubated on mechanical ventilation. Please, if we can run the video. Okay, this is a teamwork. In this video, ICU specialist, physician, respiratory therapist, physical therapist, nurses, either the trainee in the physical therapist field, they are joining us. So NASAM is a teamwork. Early mobilization is a teamwork, starting from the doctors, physical therapist, social worker, nursing, respiratory therapist, etc. Can we take the next slide, please? So when we start to make a decision to enhance the mobilization, we make a meeting to see our strength point and weak point, to analyze the situation, and to organize a plan of work. Can I, next slide, please? So this is a symbol of we make it on a weekly meeting. In this meeting, we will discuss, we have an agenda. The agenda will go with will end in the recommendations. In every meeting, we will discuss if this recommendation was done for the last week or what the barriers. It is like the same what in NASAM, in the mobility bundle, the barriers to achieve highest mobility level, it is the same. What the barrier to achieve our recommendation from the previous meeting? Next, please. So this is meeting also all physicians, head of department, physical therapist, ICU consultant, nurses department, all the team will be in this meeting. Next, please. So this is some sample of meeting agenda that we analyze, that what the barriers of the mobilization, how the staff is, how the knowledge of staff about the mobilization, machines, availability of machines, how we can make harmony between the physical therapist, the respiratory therapist, the nurses, the physician, the sedation vacation, the spontaneous breathing trial, all should be in the same harmony, that we can mobilize the patient. You cannot move patient who's still sedated. Next, please. So this is our number of patients now for the NASAM bundle, 3,225 patients for the mobilization bundle. we reached almost 1,289 patients. Next, please. This is our data collection sheet. Next, please. Yes. Yeah, now I will give the mic to Sarah to start speaking about her experience in mobilization in our ICU, and in between might I help her. Okay, can we give it mic to Sarah, please? Miss Sarah, Dr. Yassin. Hello?
Yes, Miss Sarah, you can go. You can proceed. Good afternoon. Yes, Miss Sarah, you can proceed. Hello?
Yes, Sarah, you can start. Go ahead and start.
Yes. Good afternoon, everyone. Can you hear me?
Yes.
Hello? Yes, okay.
Yes, we do.
I was working ICU before starting NASAM project. Actually, we were having a problem to detect which patient can be improved and mobilized out of bed. I often felt a great responsibility towards that. And from this point, I started to look up for a solution. And I found many resources helped me to organize this protocol and discussed and approved via ICU consultant. First of all, once the patient is hemodynamically stable, please can you move to other slide? Can you press on protocol, please? Yes, next. So first of all, once the patient is hemodynamically stable, we start, sorry, no, the same slides before. Yeah, great. The next. So, okay, thank you. Please keep it on this slide. I want to explain something here. Once the patient is hemodynamically stable, we start to assess him in such a way that we can determine mobility level he or she can achieve. So here we are talking about the critical cases. It was better to summarize the patient assessment as follows. First, as a neurological assessment, we have RAS score, Rashmond Agitation Sedation Scale. I think everyone have an idea about this scale, so there is no need to talk about it in details. The important things to know is that chance to mobilize the patient if achieved less than -3 or less than +2. That means the patient, if the patient have a score -3, -4, -5, will start with him passive range of motion, level 0 of mobilization. If the patient's between -2 to -3, or sorry, -2 to +2, sometimes we can get this patient out of it. The next, should check the response level for the patient. If the patient responds to 1 or 2 commands, we start level 2. Try to start active protocol. When the patient responds to 3 or 4 commands, we're trying to get patient in level 3 of mobilization. The next is respiratory assessment. I have to check the ventilation parameters very carefully in case I want to transfer the patient out of bed. And that's, it should be under the physician supervision. So we have a PEEP, FiO2, SpO2, and respiratory rate, as you see the values of each one. The next is cardiovascular assessment. We should monitor heart rates, main arterial pressure, systolic blood pressure, and as you see in the protocol, we have the values for heart rate between 50 to 140 per minute, the MAB between 65 and 140, systolic blood pressure between 90 and 160. The next is if the patient is given vasopressors, we should ask the nurse about the dose of the vasopressors. If the patient take more than this dose of norepinephrine and dopamine, we work with him in passive or level 0 of mobilization, and we check in the same time no increase in dose of vasopressors in last 2 hours. What I wanted to say here, we have the ability to make a clinical decision with the physician in some cases to progress and get the patient in higher level. We should rule out myocardial infarction, any active bleeding, open abdominal wound, unstable spinal or limbs fracture. After we check that, what I wanted to say here, if the patient meets all these criteria, we can work with them in active protocol and progress to a higher movement levels. However, when it does not meet this criteria, it will also be under physical therapy, but in level 0. So these stages explain to you each level of mobilization and what we can give each patient add a dose of exercises. Next slide, please. With Dr. Hassan.
Okay, good afternoon again. So to achieve this, we start to survey the staff about their knowledge about the air mobilization. We put a survey of multiple questions with choices. We get 2021 response from the staff, either electronic or handmade. We collect the data and we collect it and we analyze it. Can we take?
It's taking time.
Hello?
Finished. He should.
Yes?
There's so much echo, so I'm gonna mute everybody and you can unmute yourself. Okay? There's so much noise. Maybe you can do it from there.
Hello?
Aywa?
Okay. So this is an example. Can you hear me now?
Yeah. Yes. Very clear.
Yes. So this is an example of the survey. We asked the staff about their knowledge that if early mobilization will help reducing or weaning the patient from the mechanical ventilation. Is it increasing the awareness of the patient? Is it multidisciplinary team approach? Many questions. We are asked to screen the staff about their knowledge. Next, please. Okay, next. This is all the question of the survey. Then we collected the result. Okay, can you press on any one of this? It will be maximized. Okay, this is about the information according to the profession of the people working in the ICU. Next, please. This is about their knowledge of the mobilization, meaning get patient out of the bed. It's not just making some exercise in the bed. You see, it's almost half of the staff, they doesn't know that the mobilization mean to get the patient out of the bed. So we start to work on these weak points. Next, please. Okay. You see, they are considering that the staff, almost half of the staff, they're considering that the responsibility of the mobility is multidisciplinary, but the others, they didn't think so. Everyone saying that this is a staff nurse responsibility. No, this is only the physical therapist responsibility. So this is all, this survey help us to know about this and this weak point to work on it. Next, please. So we started an education program to the nurses, training about the mobilization. Sarah again will speak about this education materials. She's the one designed it, by the way, all this, and she's the one started the education. It's all this, it is NASAM team work. She's the one work on this, and so that she will explain about this.
After we see the result of the survey, we start to organize these brochures to help our nurses, our training, everybody working here in ICU to know what's the meaning of early mobilization. So as you see, I try in the first brochure to I have just put simple sentence and simple idea about early mobilization, but it's really was helpful for them. The other I talk about mobilization, how mobilization can improve patient oxygenation. So you see, maybe it's helped us to weaning the patient from mechanical ventilation very early. Also, it helped us in get the patient more muscle powers and focusing on for accurate weakness. So prolonged hospitalization and mass loss, muscle strength weakness, reducing. All of these, it can come to the patient if he will not start early mobilization as soon as possible. Next, please. We organize these cards. Next, please. So these cards we organized to help the doctors to detect which level he wants the patient to be on, and we separate on, and we give all nurses and all doctors here in the ICU an copy of this. So as you see, we have the level 0, nothing, and level 2, transfer bed to chair without standing. Then level 3, sitting on bed. Level 4, sitting at edge of bed. And to level 7, it's walking. When we start from 0 to down, we will reach level 7 of mobilization. The other side of the cards, it's the early mobilization contraindication. We did that for patient safety, so it's really help us in involve the patients in who is contraindicated for mobilization. Next.
Okay, so when also we start to analyze some weak points, we discover that even we have a problem with referring patient to the mobilization. Before, we have a very old process that that time there is no mobility team in the ICU, just physical therapists coming from their department to the ICU to do certain job. So they will receive referral like from orthopedic, please move this knee. From surgery, please concentrate on this part of the body. So no one will look to the patient as a whole patient for mobilization out of the bed. Okay, for the ICU, we saw that this is a weak point and we have to work on it. So we changed the referral form. We make our own ICU special referral form. This is only for the ICU patient. We name it an early mobilization form, referral form. Actually, this we can name it, we like to name it as the prescription of the mobilization. This will give us the dose that the physician, the ICU physician, whatever the patient under treating physician of orthopedic, general surgery, medicine, whatever, the decision of mobilization should come through the ICU physician. ICU physician, because he knows the patient as a whole patient, he will decide what the proper dose of mobilization is suitable for this patient as a whole patient, so he can decide when this patient can go out of the bed. So that's we like to name it not the level of mobility now. We try to name it in the ICU what dose of mobility this patient is receiving, because we consider now it is part of treatment of the patient. It's not something added to the patient. No, it's part of the treatment of the patient. Next, please. Also, you have, when you are making an improvement, you have to support yourself with some machines. This is a recent machine we received. It's helping patient in balancing and supporting the trunk and the lower limb if the patient is complaining of or suffering from weakness. Maybe Sarah can talk more about this machine and its use. Start, Sarah.
So this machine, it's help us for helping patient or get patient from sitting at edge of bed to standing. Sorry. And also it's a balance machine. We use this machine for train the patient on static balance and dynamic balance. This machine connect, as you see, with the monitored or biofeedback. Once the patient start to standing and start to do a balance exercise, we have some game in this screen, so the patient can move right, left side, up and downwards. So it give us how the patient can progress and how the balance of the patient improved. So as you see, these two videos, it's a workshop when we start to use it. Please press it. And we start use with yes. Skip, please. Next slide.
This is our last update about the mobilization. We just started in the ICU. We have just now only 6 cases about family engagement in the mobilization. Some patient of level 0, you know, this is a staff issue everywhere. So our mobility team can run from 8 to 4 p.m. Some family, we saw that some family is offering that they can help us with the mobilization. I mean, in such level of mobilization, especially like level 0. So they offer that we can also take care of our patient in the afternoon and in the night if you will allow us in certain time to come. We started now to apply this in the ICU. We will call a relative in certain time. We are making a schedule for this patient. This relative will come in certain time. He will join the dose or the session of physical therapy or the mobilization with the physical therapist. He will receive training on it. He will just observe in the first, then he will do half, then he will do full. When he got a fit certificate letter from the physical therapist that this relative really can do this level like 0 safely to the patient. So we will allow him in certain time to come in the evening or in the night with coordination, with the staff nurse and the other administrative issue. Family with the 6 cases are happy. Even some of them discharged from the ICU to the ward. They saw us there. Really, we can help even we can help our patient in the ward. Thank you very much for this. They are telling us. This is some appreciation certificate. This is our medal that we are appreciated and we are proud about it. That how patient is talking about us. This is some example of patient their patient was in the ICU and discharged. This is some appreciation certificate. Next, please. This is another one also, another example. Okay, like what we said in the beginning, it is a teamwork. Leadership is very important, supporting and managing, really managing some problems, coordinating with other departments. Without a good leadership support, you cannot achieve any successful in any project, especially in NASAM. Also, I want to thank your support, Dr. Yasin, Dr. Zohair, and the coordination from Cheryl, Dr. Bashir. Really, I want to thank Dr. Bashir. He's a great man. He's a hard worker. And also Miss Iman. Always they are responding to our call, to our query. I want to thank all of you. Please, if we can proceed to our videos, that you can have finally some idea about what we are doing with our patient on fact. So please, Cheryl, if we can start the success story of Asir. Yeah. Voice, I think it's a mute. Sound, Cheryl, please. Hello? This is rehabilitation of brain trauma. Yeah, the last video, Cheryl, please. It will take less than 1 minute. The last video, please. Yeah, this is no sound. I like this video. It is a 60 years old female COPD patient, prolonged ventilation, almost more than 45 days, steroid, trachestomized, but she was discharged from the ICU walking. We like this video too much in ICU. Thank you very much. This is what we did. I hope that we did something useful for the patient and for the others. Thank you very much for all my NASAM team and for all the administrative people, and especially from the member of our team, Sarah Al-Malki. She really was a great gift to the ICU when she was started the mobilization in the ICU. I want to thank her. I want to thank all of you for the listening to us today. May Sarah say something?
Thank you for let us sharing our experience. I want to thank to Dr. Hassan. He's very great leadership. He is with us since January 2019 until now. So thankful to him, thankful to Dr. Ibrahim, and for my colleagues in physiotherapy. Thank you to all ICU staff. Thank you, Dr. Yassin.
Thank you very much.
For Dr. Zuhair.
Congratulations. This is really remarkable work. This is something we're all proud of. Definitely clear, positive work that will help patients. I think there's no doubt about it. And I think your team is doing really, really great, working together, achieving very important goals, and really a role model for other ICU. So we're very happy. And thank you for putting this presentation together. So for all of us to see how we are doing, this is really remarkable. And keep giving us updates every once in a while. I think it's very useful for all of us to learn how things are going. I'm going to ask Dr. Zuhair Asiri if he wants to make comments, and then we'll open it for other people if they want to make comments.
Is Hassan and Sarah listening now?
Yes.
Hassan?
دكتور حسن.
Yes, Dr. Zuhair, I can hear you,
Great.
sir.
طيب, thank you very much سارة وحسن وإبراهيم العسيري and all the ICU team, and many thanks as well, many thanks as well for the administrations in Asir Hospital for the support. طبعا without your presence, you're enthusiastic about the work, I'm sure that the leadership will not be supporting as well. But start in the department and supported by the administration, and Asir raised the bar, صح? Asir raised the bar. So congratulations for all of you. That's achievement, and you know, you put us in very bad position that we have to work harder with other hospital to achieve what you guys achieved. So, and the main thing is to sustain the achievement. It's not only one time or because NASAM and the Prof Yassin behind us. It's just we have to continue this work forever. One day we will be a customer in any ICUs in the country. So we have to make sure the level of service in the ICU is up to the level, and Asir bought the model. So congratulations again. شكرا يا سارة. شكرا لك وللتيم اللي معاكي. شكرا لحسن وشكرا لابراهيم العسيري وشكرا للاداره كامله. يعني فعلا excellent work. ايضا الاستشاريين كلهم، ما ودي اذكر اسماء عشان ما انسى احد، بس ما بنسى اكيد الدكتور عامر والدكتور طبعا البروف ان شاء الله علي البشابشي for their extreme tremendous work toward success achievement. طبعا all of this ما كان حيحصل, it will not happen without the presence of Prof Yassin and his crews and National Guard to support us, to guide us, to be part of the team. We are very delighted and happy to be part of this nice work. And you know what, we are adopting it, and we'll be a leader in it as well. It's not only we learn from them, and we'll be a leader in the Ministry of Health. I can't express my feeling anymore, but you know, definitely we take a message that we will little bit, you know, do more work in another institute. شكرا لكم جميعا. Thank you very much Hassan and your team. Thanks a lot.
شكرا دكتور زهير على دعمك. شكرا للجميع. نتشرف بزيارتكم لنا في أبها. الأجواء جميلة جدا هالفترة. يعطيكم ألف عافية.
So thank you very much. Many comments on the chats congratulating you from different hospitals, which is really remarkable. I would like to use the next few minutes to open it for people if they want to make comments from other sites. I think will be open if there are any comments from our team here. Any comments? You could write on the chat also if you want, or you can unmute your microphone. I think this presentation just tells you that what's needed is committed, to have a team that is committed, working together. And early mobility, as I said, is part of a program. You have to fix the sedation, weaning, etc. But a lot of it relates to working together as a team and having clear goals. And certainly you are seeing in many ICUs now mobility, more examples of early mobility, and I think we need to keep it up. It's very important. Any other comments? Our team, nurse managers? I just wanted, actually, while you're giving presentations, Sarah, if you want to share some of these posters, if it's okay with you, and you want to put them on the website so other people may use them to guide.
Yes, sure.
And the protocols, whatever you like to share, you can put it on the website so people may find them handy to adopt or revise for their local use. I think would be very useful.
Yeah, it's my pleasure.
Yeah, so then whatever you worked will reflect and impact other sites as well. It will be good for you and everybody. Any other comments? So here saying great effort. We're doing it with pediatric patients in cash. We like to see that in our adult ICU. Okay. Yes. Agree. So we need to do this. Mobility needs to be observed, and I think we need the help of the nurses, the RTs, and physiotherapists on pushing this agenda forward. There's a question about whether mobilizing patient, mechanically ventilated patient. So Dr. Ahmed Al-Madi put a great comment here. I think it's very great, so I will read it because I think it's an excellent point. So he says, really great job. You change the practice of early mobilization from being luxury to standardized care. So this becomes really not something we should be rare incident, should be the standard of care, which I fully agree. So fantastic point. And
thank you, Dr. Yasin.
yeah, Dr. Ahmed. So if you are here, maybe you can make a comment.
Well, sorry, my mobile was charging off, so I'm using Bashir. Really, well, I'd like to thank them so much. Really, I can feel the making as mobilization, which is most of the centers looks like a luxury or something which is most not as a standard of care. But Asir people, actually Sarah, Hassan, and all of them make it look like a standard of care. I can see actually multiple levels and those of mobilization for the case. And as you mentioned, Dr. Yasin, really it will be very good sharing experience together. If you are sharing your survey, your posters, your videos, really we are happy to share with you with your experience in that very good achievement.
Yeah, fantastic. So whatever material you'd like to share, please let us know and we can post it there. I think also we need to, like what we've done today, we need to see successful examples. So any ICU wants to share their experience, or we'll be happy to accommodate it, because I think this is a real learning from this from these webinars, to see how other people are doing things, and we can all learn about things done. So there are Asir has been a great example today, but we'll be more than happy, I think, coming webinars to hear from other ICUs as well.
No problem. We're proud of all your words, and we will share all our materials. It's our proud to share it with you, especially you, Dr. Ahmed Madi, and your experience, and Dr. Yasin, Dr. Zuhair, all, and other colleagues from other hospitals. We will share all our materials with you. Thank you very much for your kind words. Thank you, really.
Thank you very much. I think with this, we'll conclude our meeting today. And so keep it up. I think it's remarkable work. Thank you very much, everybody.
Thank you. Thank you very much.
Thank you.
Thank you very much.
Yeah,